Welcome back to PT Meal Podcast, a buffet of play, therapies, movement, exercises, activities, and leisure, all packed in a hearty conversation of the physical therapy profession and practice with a Filipino flavor. I am Johan Del Paz, your host. Welcome to the banquet. This PT Meal Podcast is available on your favorite podcast streaming apps. You can also watch most of the full episodes and live streams on YouTube. If you want to stay updated on everything and anything about the podcast, follow the podcast social media accounts. Check our Etsy store as well. Search PT Meal Shop, one word, PT Meal Shop at Etsy for some of the merchandise. All links and content are available in the website, ptmealpodcast.com. Okay, so before we proceed to the recap episode, I just like to congratulate everyone who has successfully passed the recent Philippine Physical Therapy Licensure exam. So welcome to the profession, and to those who weren't able to make the cut, don't worry, your dream is still there. It's still alive and reachable. You just have to face that challenge one more time. Remember that it's not just the destination that matters; it's also how you get there and how you persevere. So, all right, again, congratulations to everyone, and good luck to those who are going to take the exam again uh, this year or next year. Anyway, so for today's episode, we are going to recap all of our recent conversations. We'll hear highlights from those episodes. We'll start with our conversation with Jonathan Eusebio, sharing his experience as a physio in Singapore. Next would be Oliver Rivera as a rock climbing physical therapist treating rock climbers. And then yours truly sharing with you about how it is as a physical therapist in a forensic psychiatric setting. Then Regina Araquel talking about pain education and working with other professionals like acupuncturists and chiropractors. Erwin Valencia on mindfulness and gratitude in the NBA. And lastly, Janise Alcantara on making her way to earning a Doctor of Science degree in physical therapy. So, truly some rocky roads ahead, but by uniting our minds and bodies, we'll surely overcome any challenge. That's our episode title for today. All right, so here it is. Enjoy the episode. What is the role of a physiotherapist in Singapore as compared to what you did in the Philippines? Is it basically the same? Are there any differences?
Mhm. It's I would say it's just basically the same. It's just that in Singapore it's more structured. Um we also don't have direct access. Probably Singapore will have direct access. I mean, a patient can refer themselves to a PT. I think only in private, but in public you have to get a referral from another healthcare professional. But the same process as to how you do your thing. I mean, assessment and treatment and everything.
Mm-hmm.
Yeah, yeah, and
Is
also different settings.
different setting as well. Is insurance a big driver in Singapore as well, or do patients pay out of pocket?
Okay. Insurance plays a big part. It's because at least, especially for the elderly. Anyway, in Singapore, usually they pay up the government for a certain amount, and then that is being used for anything like a physiotherapy services.
Mm-hmm.
Um, they also can use their own insurance if they have one.
Mm-hmm.
They have what it's called, I think, a means testing. Depending on your age, if you're a younger one and are capable of paying and you don't have any insurance, you have to pay from your own pocket.
Okay.
Yeah, I
Mm.
think.
All right. And you mentioned there's no direct access.
There's no direct access. Generally in Singapore, you have to have a other healthcare professional to refer you to a PT.
Mm-hmm.
That's only usually in the public or
Okay.
government house, but usually private, you can go directly to a physio.
Also, so there's some form of direct access in
There's some
outpatient
form.
setting. I see. All right, that's nice. Um, so you're working in a hospital right now, right?
Mm-hmm.
Are you an inpatient, outpatient?
I am in the inpatient setting.
Inpatient. All right. Um, what kind of what's your common conditions that you handle in your practice right now?
I do have a variety of cases that I usually see in the hospital, but most of them I believe it's in the ortho cases.
Mm-hmm.
I do have also some medical conditions like cancer patients or palliative patients. I
Mm-hmm.
have neuro, stroke, Parkinson's kind of cases
Mm-hmm.
once in a while. Yeah, they're also, I mean, most of them are in the geriatric or elder population, but I
Mm-hmm.
also do get some younger ones who
Mm-hmm.
had an accident or road traffic accident and fractured their bones or whatever.
Mm-hmm.
Yeah, I have a lot of arthroplasties, hip and knee, and then some spine operations. That's why it's mostly more often MSK.
Uh-huh.
Yeah, that's
All right.
generally my practice.
Is it, are your patients condition more acute, or are they staying in the hospital a little longer?
No, it's not acute. We're the next to institution in line after the acute setting. It's because um our hospitals are usually coming from the general hospital, the acute setting.
Okay.
Usually they stay there for a few days, a little
Mm-hmm.
longer sometimes. Then if they need a further rehab, or then they will be referred to our hospital. And that hospital is just next to our community hospital.
Okay.
They're under a Sing Health system.
Uh-huh.
That's why
Okay.
they from the acute hospital they will just be transferred to us if it's agreeable
Uh-huh.
with the patient's family.
Uh-huh.
Yeah.
If they needed more care
Yeah.
and they then that care cannot be done at home or an
Yes.
outpatient facility. Gotcha.
Yeah, correct. Usually if they need it.
Uh-huh. All right. Um, being in diverse, culturally diverse country like Singapore, is there any challenges? Were there any challenges handling different cultures or working in Singapore as a physiotherapist, or was it
Mm,
easy?
It's not that very easy,
Uh,
especially for me coming from the Philippines.
mm-hmm.
Yeah. Cultural backgrounds. I mean, we differ in many ways.
Mm-hmm.
Also the language that they speak. I
Mm-hmm.
mean the elderly population. So most of them don't really speak English.
Mm-hmm.
So there are some elderly who can, I mean, educated and can speak the English language. I can easily talk to them.
Mm-hmm.
But if not, especially if they speak in Mandarin or Hokkien or
Mm-hmm.
even Cantonese or sometimes like dialects like Tamil, it's very difficult. Sometimes I really have to get someone, my therapy assistant, if let's say I'm a physio now, um, who can speak the language and help me translate.
Mm-hmm.
Yeah, so the interview, the assessment process takes a little longer because there has to be translation
Mm-hmm.
during that time. Um, and I also didn't, I mean, it's not also a requirement in Singapore during the credentialing part, because we were not allowed to take a course regarding cultural differences.
Mm-hmm.
Yeah, because I believe in Australia or in Canada, you have to take a course similar to that and also study the healthcare system. Here in Singapore, it's not. You will learn that while you're already working.
As you go on.
Yeah.
Uh-huh. And so uh did you have to learn any language? Did you want to learn or have to learn any different language to work in there better or
Yeah, I did. Actually, there are a few courses offered outside. I enrolled myself to one. I wanted to study Malay because some of my patients speaks in Bahasa
Bahasa?
Malayu.
Uh-huh.
Yeah.
Yeah.
So that one is quite easy to learn. It's
Uh-huh.
because Tagalog and Malay are quite similar. There are some
Right.
words that are the same,
Uh-huh.
although sometimes spelled differently, but meaning is just basically the same.
Uh-huh.
Um, I do that, and I actually in the work setting, you will be put to a course by your employer in studying Mandarin or Hokkien or sometimes even Malay,
Mm-hmm.
especially if you're a foreign national. For but I find it very difficult, especially the Mandarin and Hokkien, because yeah, I have to study the different tones. Is if you say
Mm.
it wrongly, that meaning changes. And
Uh-huh.
then if you ask that to a patient, the patient sometimes will just frown, or sometimes they don't really understand you, or
Uh-huh.
will tell you differently, or something, get scolded.
Uh-huh.
So
Uh-huh.
what I do the best is, I mean, to have a translator to help me translate for
What are
everything.
the advantages of treating rock climbers, being a rock climber as well?
Yeah, so I mean, you hit the nail on the head that knowing the jargon. In
Mm-hmm.
one of the studies that I'm currently writing the manuscript for that project for that research study, and one of those studies cited that I think it was over half of recreational rock climbers that get injured don't seek medical treatment because they feel that their healthcare provider doesn't know about rock climbing. So
Mm-hmm.
that's a pretty big number right there.
Mm-hmm.
And I know like severity of the injury may play a factor if they think they're going to be fine without seeing anybody, but still that uh, a distrust almost in your healthcare provider is a reason to not go see them. That's a pretty big thing.
Mm-hmm.
So I think when you find someone that, or when a patient finds someone that they know at least has some experience, that's the person that you want to go to. Like if you're a musician and you saw a PT that specializes in musicians, like that's the person that you want to go to.
Right.
So I think for me, knowing that lingo, knowing kind of the demand that they have to go through, that it's just not all arms, it's how you use your legs, it's how you can control your center of mass along a wall,
Mm-hmm.
what a dyno actually feels like when you're jumping
With
from
what?
one hole, like a dynamic move. They call them
Okay.
dynos.
Okay.
Yeah, yeah.
I thought you were talking about dinosaur.
Okay. Yeah, yeah. But just yeah, that's the specific fear
Mm-hmm.
and kind of that mental challenge that you have to overcome with it. I think it helps, and I think that's why the majority of people that rock climb kind of seek me out that I've treated just
Mm-hmm.
because of that familiarity with what they have to do.
Right. I think it's like what you said, like if a musician or dancer would be injured and would seek someone who understands what they're doing,
Hmm.
musician or a dancer as well, similar to people who lift, they would seek someone who knows how to lift as well. So same thing. When you're seeing rock climbers and their injuries, what are the common ones that you usually see from rock climbers?
Yeah. So um, typically, uh, it's like the big ones, obviously, like a pulley tear. So when someone tears one of the pulleys that's holding down their flexor tendons in their fingers,
Oh, okay.
that's probably the biggest injury that is associated with rock climbing.
Mm-hmm.
Those are always tough because if it's fully ruptured, like there's not much you can do in terms of rehab, besides strengthening everything else around it,
Mm-hmm.
and then kind of managing pain. But in addition to that, you can see like TFCC tears at the wrist. You can see flexor or extensor tendinopathies at the elbow. There can be neck pain associated with constantly having to look up at your next route or having to belay someone,
Mm-hmm.
just watching them move. There can be rotator cuff strains, ankle sprains from falling. My last one was actually an ACL tear when she fell from a
Oh
bouldering
wow.
problem. So I was rehabbing her, trying to get
Uh-huh.
back to climbing. So I think it's a wide variety just because of the nature of the sport, that it's not just using your hands, but it's also kind of the falls that you.
So what would be your advice to physical therapists who are thinking about going into a specific population or practice? May not be rock climbers, but thinking about where they can excel at. Probably they know a sport that they want to go into and focus on those uh, population. What advice can you give them to excel in the area?
Yeah, I think just uh, coming at it from a population perspective, you have to know like that population. So you have to be where they're at. So if you're wanting to treat climbers, like the best way is to have exposure to them. So be part of that gym, offer that gym different educational series, simple stuff, whether it's like finger health, wrist health, elbow health, something
Mhm.
injury prevention wise. Um, you have to be a familiar face. You have to know kind of what you're talking about with that sport. And you have to show that you're knowledgeable.
Mhm.
But for anything really, it's doing the basics well. So as PTs, we're movement experts. You have to be able to analyze that movement um, very well and efficiently. You have to know every single potential diagnosis that might be happening.
Mhm.
And you have to have a little background in pain science, because some athletes are pretty straightforward, other ones can be head cases, and that all affects their perception of pain. And you have to be able to know how to kind of progress that athlete to those different levels based on where they're at in their stage of healing.
Mhm.
So a lot of different things there, but I think the number one thing is just doing the basics really well.
Mhm.
And that's what my residency training taught me, and that's what my fellowship training taught me. Is there's no really secret to it. There's no like one system that answers all. It's just about knowing how to assess someone very well and to make sure that you're treating the right thing.
Question is, why is it called forensic? Okay. Um, when we hear about forensics, we remember or we think about the TV shows like CSI, you know, forensic investigations, DNA, crime, stuff like that. But if we look at the definition in the dictionary, forensic is anything relating to courts of law. And if we go to what forensic psychiatry is, it's a clinical subspecialty that is concerned with helping people who have mental disorder, who present a risk or a significant risk, and may have been in trouble with the law. So those who have pending cases, who have been tried or not have been tried because of their um, mental disorder. So in the hospital, what the patients are usually there for is, or what the doctors are there for, is to determine if the patients are fit to be released in the community, if they're fit to be released in a supervised home, or if they're uh, supposed to go back to the prison, or if they're competent to stand trial. So I could think of two types of settings in this, you know, forensic bubble, which is the psychiatric hospital and the correctional, right? So in both settings, there are physical therapists. So there are physical therapists in prison. So but what we're going to focus on here is the forensic psychiatric hospital where I'm working at. Right. So how complex are the patients? So as I've mentioned, the most common, you know, conditions that they have are, you know, psychiatric conditions, schizophrenia, bipolar disorder, and neurocognitive disorders. They would present with um, behavior, maladaptive behaviors, psychosis, you know, hallucinations, uh, so mood, um, lability, uh, changes in their, you know, cognitive and mental status, again, medication side effects, and other medical comorbidities. So uh, it's important to recognize those behaviors and uh, to be able to adapt to how the patient is presenting at a specific time of the visit. So what I usually do, when I see a patient, before I see a patient, I go to the nurses or the staff first and see how the patient is at that time. Sometimes they're okay, sometimes they're not, and when, you know, when if they're in not in a good place, then we reschedule. You know, the important thing there is that they're being medicated, they're being seen by their other professionals, by the other um, members of the healthcare team, and when they're fit and they're good to be seen for their physical impairments, then I'll come in. Then we'll talk. So, is it challenging to treat patients in this population? I would say yes and no. For um, yes, because of those other factors, the psychological facts, psychiatric disorders, psychological symptoms that presents the challenge. Okay, sometimes I would encounter patients that are manipulative, patients who are malingering. So that presents that a lot of challenge there, because um, with their, you want to acknowledge the patient's subjective complaints, but at the same time, you also want to um, see if you are there, that your presence there would be beneficial for the patient. If you're there to feed on the patient's, manipulation into their attention-seeking behavior, then probably you're not there as something that is good for them. But the challenge there is knowing what role and part you can do for the patient. If that is talking to them through their, pain, or explain them how their condition is affecting them, then that is good. In my practice before here, I don't usually encounter patients who are malingering, patients who have something to gain to get when they get physical therapy. But here, you get those kinds of patients, and you have to determine how much help you can give and how much of your time will be beneficial for you and for the patient. So that is where that interest came when I started working here, and I got to dive into what is, how would you determine malingering patients. It's really a hard thing to do, but you have to work closely with the other members of the healthcare team that sees the patient more often than you. So in the unit, there are patients, there are staff that stays there. They have specific nurses there, psych techs, their own psychiatrists, psychologists. So they're really closely monitored. And I'm the one that, comes in, comes out, doesn't stay in one unit, goes around the hospital. So it's important to get the input of the staff and the overall picture of the patient. Maybe in my session, the patient keeps on complaining about his back pain, and it's 10/10. But the doctor, the psych techs, the nurses would see the patient, running in the courtyard and stuff like that. So the approach would be different for those. So that's where the challenge lies. You want to be respectful to what the patient is, saying, but also seeing up to where, the benefits of your visits would be. That's where the challenge is. Sometimes no, sometimes it's not really challenging. Sometimes it's you just see a patient as you normally see in an outpatient facility. Patient comes in, tell you that there's a complaint. Patient is very agreeable in performing that treatment, doing the home exercise program, and that's it. And then you go. Easy peasy. So it varies in days, it varies in patients. So it's I think that's what's interesting in this kind of setting.
Psychological part only happens when you're in the session.
Mhm.
So like CBT is always about redirecting thoughts. So cognitive behavioral is you redirect the initial thought so that the train all gets redirected.
Mhm.
So it happens in a session.
Mhm.
Ang mangyayari is while you're stretching the patient starts talking about, I don't know, but I believe that there's something about when you stretch people, when they feel a release, they actually voice out something that, that's been bothering them.
Mhm.
So then there's your opportunity. Now, maybe if you try to think about ito, like, maybe try to think about when you're in pain. And the number one I want to practice is think of pain as neutral. Yun yung number one ano ko. If you accept pain, it ceases to become your enemy. Yun yung sinasabi ko lagi. So you treat the pain as something is not in harmony in your body. And now we're working to harmonize whatever is not in harmony. And we're looking to ease whatever is in this ease. But for that to happen, you have to stop resisting pain.
I love that.
Yeah. Kasi pain is neutral. Kumbaga. Once they start accepting that concept that it's neutral, stop fighting it, nagde-decrease yung pain. Which is true. So then after that, yung dis-ease, nare-relax. And to my patients, I always say, nothing can resist a non-resistant person.
Nice.
So if you're not resisting anything, wala kang mararamdaman. Okay, nandyan yung pain, okay. But if you consider it as neutral, and then you just tell it to leave your body, it actually leaves. Kasi you don't recognize it as kaaway mo. So we start with that, and then, the acupuncturist takes over, and then tapos na ako mag-stretch, and then they go back the same time again, and then another technique that we actually started using is, especially for stretching, we try to incorporate breathing. So the number one underutilized mechanism of the body is breathing. How many people in the world do you know actually take a deep breath every day? So now, instead of stretching the patient and then counting, so usually we begin stretching, you hold it for 20 to 30 seconds, you do it 5 to 10 times, ganyan. We stretch a patient and then ask them to do 5 deep breaths. Because in that way, the muscle you're stretching actually moves by itself than just being, statically stretched.
Right.
And also, we take advantage of the benefits of deep breathing. So they actually, and it's so amazing to see when you do deep breath holds than just holds for stretching. Sometimes hindi mo na kailangan ulitin.
Sometimes hindi mo na kailangan what?
Hindi mo na kailangan ulitin. Pinagawa mo
Okay.
siya. For example, stinretch ko siya, and I said, take 5 deep breaths while I'm stretching you in this position. After that, we do it again. Sobrang stretch na, we don't even need to do it again. So that's what we found out in our practice. So yeah.
I like that. I like that when you say that you tell your patients that pain is neutral, because all our lives we've kind of villainized pain. It's not supposed to be there.
It's not supposed to be.
That's what we were taught. Pain hurts, pain harms. That's it. We don't like pain.
Yeah.
Yeah. I mean, sino ba naman yung gusto mo saktan? Pero
actually, wala na akong gusto.
Wala na akong gusto. Pero I mean, it's neither good nor bad. It's just there.
Yes.
That's a good perspective.
It's a marker. Like, pain is neither good nor bad. It's there to tell you something needs to be fixed, or something is not in the right place.
Yeah.
So once you move past pain and you actually look for why is it hurting, then hindi ka na interested uminom ng pills. Hindi ka na interested with surgery or anything. Which, of course, I'm not opposed to surgery if you really need it.
Need it, yeah.
Yeah. Of course, if collapse na talaga yung vertebral column or meron na talagang bone deformity or whatever,
Right.
of course, you need it. But anything that is chronic, anything that is chronic is always something caused by disease.
Right. Kasi when there are pain, like we know exactly what it was caused, then it's easy to address, like mechanical or like an ankle sprain. Alam natin, it's gonna heal at this amount of time and stuff like that. But chronic pain, especially, is very complex. That it needs more diving into, not just like you had this and we're gonna do this and that's it.
And because we're into a practice then combining traditional Chinese medicine.
Mhm.
In Chinese medicine, unless your condition is caused by trauma,
Mhm.
like for example, syempre pag nabalian ka ng buto or binaril ka, whatever, then that's a different case. But anything outside of trauma that you just started feeling gradually or kahit biglaan, it's kind of like they consider it as an more of an imbalance of something
Mhm.
than an actual there's something wrong with you.
Mhm.
It's not a disease. There's just an imbalance of something, and
Mhm.
once you balance it out, it actually gets rid of your pain,
Mhm.
your disease.
So you're working in a holistic clinic, and you're working with professionals that we traditionally don't work with as physical therapists.
Yeah.
How was that adjusting? Like, because they're with acupuncturists, in Eastern studies, they're
Mhm.
like on meridians, on
Mhm.
energy flow and stuff, chiropractors, adjustments and spinal
Mhm.
alignments. How is that adjusting with their practice, and including and putting in your foot there, and including what your practice is about?
Um, at first, parang it's very tricky
Mm-hmm.
kasi in some ways your practice really overlaps
Mm-hmm.
with some of their practices. Like, naga-hands-on din yung acupuncturist, naga-hands-on din yung chiropractor. And then may massage therapist kami.
Oh
So
yeah.
parang sa akin, bakit pa ako magmamanual?
Uh-huh.
But then, when you know what you're bringing to the table,
Mm-hmm.
you never have a problem, actually.
Okay.
When you know what you're doing and when you know what you're bringing to the table in a practice, you never get lost. Because there's always something you can do that only you can do.
Mm-hmm.
So say for example, nag-manual na yung chiropractor, nag-manual yung acupuncturist, nag-manual na yung massage therapist, iba pa rin yung manual mo.
Mm-hmm. Mm-hmm.
Iba pa rin yung gagawin mo. Iba pa rin yung way kung paano mo hawakan yung patient.
Mm-hmm.
All the techniques are different.
Mm-hmm.
Even from one PT to another, iba-iba eh.
Sure.
Like your patients don't like it kapag pinapasa-pasa sila sa iba-ibang therapist.
Mm-hmm.
Kasi iba-iba yung treatment style, iba-iba yung treatment technique. But yeah, you never, sometimes, yes, nag-overlap. But then, again, if you have very specific techniques and then you have different goals, like, for example, manual lang naman yung usually overlap.
Mm-hmm.
Pero iba-iba yung goals namin for doing manual eh.
Mm-hmm.
Like ako, ito yung gusto ko i-address, yung chiropractor, yung gusto niya i-address. Iba-iba kami nang ina-address. So in a way, hindi rin kami nag-overlap at all.
Mm-hmm.
Yeah. Na mayroon kaming, like, na-maintain namin that we're staying in our own lanes and then we give what we do best.
Mm-hmm.
Yeah.
And you said you talk to each other naman,
Yeah,
communicate
always.
what you do.
We always communicate.
You mentioned breath work, meditation, yoga. People would say this alternative. How were you able to convince the players who are like, when we say basketball, NBA, we think about strong, speed, strength, and we don't usually think about them doing yoga, doing breath work. How were you able to get them into those techniques and participate in those?
It begins as we talked about earlier. It begins by me being it.
Mm-hmm.
I think if you are authentic in what you do, and then the world catches up to that,
Mm-hmm.
and then the players realize that you are that person,
Uh-huh.
and then now they ask the questions, and once they're finally open, then they'll allow you to teach them. But also the entry point, I
Mhm.
came in as a respected clinician and scientist.
Mm-hmm.
I think they knew me as that from the beginning. So they knew from a scientific, evidence-based aspect, there was no question that I was skilled.
Uh-huh.
There's no question that I knew what I was doing and had
Mhm.
enough experience of what I was doing. And then little by little, what I've learned in sports is that it takes about 5 years for you to be able to then show your true self and be okay with it.
Mm-hmm.
You know, there's that 5 years, even in baseball, of like, I was doing all these innovative techniques, and my head athletic trainer at the time was like, hey, you know, you can't throw out the kitchen sink everything in a year. Introduce something new once a year. and allow the players to be comfortable with that one thing that new that you do. And so that in the end, you would have introduced 5 new things that nobody else in baseball has ever done. But you were one of the first, but then you already gained the trust of all the players that you were doing the normal stuff, but then you also had a little thing that maybe got them better. And they'll always refer that like, oh, everything is normal. But then when it's really bad or they're going through something and they can't get healed or they can't feel painless, then they'll say, you know, why don't we try this one thing that you do? Then next year, it's like, oh, let's try one of those 2 things that you do. And then next year, oh, one of those 3 things that you do. So it's a slow roast and a slow introduction of innovative ideas that allows you then by your 50th year to say, you know what, you are that person. Now we trust you because you now have a tool belt bigger than anybody else in the league.
Okay. So that's what you did. You slowly introduce stuff to them and let them, experience that for themselves.
Yeah, and what's funny is, but people forget that when it comes to teaching something that's different, that's alternative,
Right.
all you can really do as a teacher is plant the seed. You can't force a plant to grow. You can't force fertilizer in it because it's going to be inauthentic. So all you can do is plant the seed, allow time to do its job, allow the sun, the elements, the wind, the air, the soil, the food to nourish that thought. And it will grow on its own. And particularly when its challenges occur, let's say, as a plant, when we're talking about, when we're using plant as an analogy, if a storm comes in and the plant doesn't know how to get back up, that's when it asks for help. And then you provide a little bit of water or you bring some sunshine to be able to make that plant grow back on. And just like an athlete, a lot of times their biggest challenge are those incidences that they have, their biggest challenges are those times that they're finally going to open up their mind and say, you know what, I've tried all these old things, maybe try something new. And that something new works for me. Guess what? I want to know more.
Have you observed any changes in the athletes that you handle once they start that journey?
For sure. It's guaranteed. The ability for them to find more peaceful time when they feel like enraged and angry. The abilities for the athletes to just be more mindful of their time and have less focus on their phones or less focus playing video games, but rather going to the steam room when we're on the road and by themselves or reading, when they otherwise wouldn't be reading because they feel like that's kind of what connects them. Or maybe now listening to podcasts of inspirational speakers or stuff like that. And I don't force all of that. I think the players find their own journey to that. And all I can do is answer their questions when they ask it, because it's something that then pushes me to also elevate myself on a regular basis.
Right. And going to that last one that you said, how does mindfulness play a role in your life?
I mean, it's played a role in my life since I was 7 years old. So I've been a mindfulness practitioner for a while. I didn't even know that it was mindfulness. All I knew, it was like I was meditating. So all I knew, I was finding stillness in the midst of madness before my taekwondo classes. And then when I was 12 and I got my black belt, my sensei was like, okay, now that you have your black belt, now you're teaching the class from 10 to 11:30. I'll show up at 11:30 for the sparring part. And I had to teach my whole class how to be silent in their minds by sitting down and thinking of white screens. And I was 12 going to 13. And some of my classmates were not only the 5 to 8 year olds. I had my classmates that were like 20s, 20s, 30s, and they were following me.
Right.
And for me, every day, my practice has helped me pause and being able to download insights of life for me to either continue to evolve or be able to face challenges when it hits the most, whether it's professionally or personally. And having a practice allows me to just be me in the most natural sense and have this quote unquote Zen feel that all my players and friends always see me as, or even new people that I meet, even doing things like cold plunges and being able to stay there for 7 minutes into my neck.
Yeah.
But with this calm face, because all I'm doing is finding myself in this space, in this mindset, so to speak, of peace that's within me.
Right. So I mentioned earlier in the intro, which I also read from your bio, that you're a gratitude coach. So could you talk to us about what gratitude is?
Yeah, I mean, gratitude, being thankful is
Mhm.
is something that we all know.
Mhm.
It's evident, and I think the funny thing is that it's become a little bit of a fad now for everyone to say, "Hey, what are you grateful for?" or give gratitude, hashtag grateful, whatever shirts. I mean, I am wearing my friend's gratitude room right now, and hoodie, which I love because of the butterflies that it has
Oh,
and the
I didn't
texture
see
that it has. This is a beautiful, beautiful hoodie, and uh, and and for me, gratitude has always been in me as a Filipino, knowing the difference between those who have and those who have not, and those who have opportunities and those who don't. We walk out of our door from our house in the Philippines, and you could either A, find somebody who's wealthier than you, but also B, find somebody who's not at all wealthy and doesn't have anything.
Mhm.
They only just have slippers. As in my classmates in UP just had slippers, and not because it was a fashion statement, it was because of something that they only had. And for me, growing up, having parents that were always good to other people, that took care of other people, that created initiatives to be able to support those that were having a harder time, I think it was ingrained in me to make sure that I stop and always be thankful for what I have.
So is that the main reason why you chose DSC, is so that you can apply that in your own practice?
I could apply it in my own practice. And at the same time, I think initially, because I think it just happened to meet my needs as to where I am in my career right now.
Mhm.
I have been a PT now for 20 plus years. And then, going to, of course, we're all encouraged to get a transitional DPT.
Mhm.
But when I look at the curriculum, I didn't see anything that was more clinical applications for me. I mean, there is clinical applications, but I didn't think I could learn any new clinical skills because I have been practicing for so long in so many different settings. I wanted something that would really challenge me, get me out of my comfort zone. And it really did. I'm talking about like really crying at times. And then and at the same time, I needed something that was, if I was going to spend this much effort, which I know what people are going through when they go through the transitional DPT, like, aren't you glad you're done? Right?
Yeah.
So I needed something like, okay, if I was going to do this, it has to be something that would, maybe in my later years, if I decide I wanted to be changed to academia and my physical body is no longer able to treat, I
Mhm.
would have that option of teaching just full
Mhm.
time. So it was sort of like it just hit all my needs right at this point of my,
Mhm.
at my stage in life. Yes.
Right. So it challenged you. It gave you
Yes.
an opportunity to apply that on your
Yeah.
clinical practice, and also served you a purpose of, in the future, in case you don't want to handle
Yes.
patients anymore, you'll be
Yes.
able to transition to academia.
Yes. And I think to answer that question also is that, you hear this from Filipino physical therapists. There's always this question: should I spend my money on a DPT, or I really want to learn more clinical skills?
Mhm.
Would I rather spend my money in continuing education and gain more clinical so I become a better clinician?
Mhm.
But do I really need a doctorate? Will it to upgrade my profession, my credentials?
Mhm.
Think about combining both.
Mhm.
That's what I think, just that to explain it in a much simpler term. So
Mhm.
you're combining that dilemma that they always have. Oh, should I go the DPT way, or why don't I just go for a fellowship in orthopedics? So this one, the program that I'm in, I went through orthopedic manual therapy training, and all the training gives me academic credits towards
Mhm.
my doctorate of science degree.
Oh,
Yes. So I
gotcha.
did it. It's like hitting two birds in one stone.
Mhm.
So how I found out about the degree was, I think I took a class with IPA, the Institute of Physical Art, right? And if they have a very good program about CFMT.
Mhm.
But while I was taking the classes, a lot of really good manual techniques, a lot of PNF, everything, it was very, very eye-opening. I learned a lot. But that's how I found out, like, okay, my question was, if I do this intervention, what is my clinical reasoning? Why would I choose this versus this and this? How do I learn that?
Mhm.
Of clinical reasoning, right? To discern that this intervention is better. No, this movement is better. No, you're going to do better with just this and this and that, right?
Mhm.
And that was, I think, the missing aspect. And that led me to the NIAM website. And I look at the NIAM website and said, oh, if I do their program, I actually can get academic credits towards a doctorate of science.
Mhm.
So, and that led me to Andrews University. So I just randomly did an application, and for some reason, Dr. Kuhlman said, okay, you need to start this year. Okay. So I didn't know, like, okay, what is this academic plan? And then I didn't even think about it. Oh, this is your academic plan. Oh, okay. And then I look at the academic plan. It's 3 years and it's 65 units. That's a lot.
Uh-huh.
I've never gone to an American university, so I don't really understand what 65 units would mean for my time.
Mhm.
I didn't really budget until I was in school, and I realized, okay, 12 units working full time and 2 kids and doing the OMPT classes, and I have an exam. This is a lot. So yeah, it was kind of like learn as you go, but if once you're in there, sige, bahala na.
Uh-huh.
Tapusin mo na lang.
If a colleague of ours listened to this episode and wonder if this might be something for me, what advice can you give to those physical therapists of thinking about if they're thinking about enrolling in a DSC program?
If I think first is they have to really decide first where they want to be further down the line. Like, what do they envision their physical therapy career?
Mhm.
Do they want to be on the administrative side more and be in the business, or do you want to be a clinician and be a better clinician in academia? So that path alone will tell you what higher academic degree.
Mhm.
And because if you are more into the business, private practice ownership, do you really need a DSC? No, you can be a successful private owner and be a successful businessman without that degree.
Mhm.
But if you want to be in the academia and you want to have higher clinical skills, and you have to have a conscious decision that you are going to have the terminal academic degree. And there are so many DSC programs out there. There's PhD, ETD. So there's a lot of different terminal academic degrees. You go through the APTA website, it will have a list.
Mhm.
Take a look at the curriculum. Is this going to meet what you envision your career would be in the next 20 years, whatever is left of your remaining practicing years? So where do you envision yourself to be?
Mhm.
And will this program, and then of course you take a review of the curriculum, because there are so many focuses on this DSC program, right? So it will, I think, for some it might not be appropriate, for some it will be, but it really all depends on what you aim for, right? And what's your goal for the next 20, 30, 40 years.
Mhm. And just like you, I think another thing to take into consideration is their current situation, because you just like what you said earlier, it's the proper timing. If you said that you haven't done it before, probably it's not the right time, but you're at the time of your career that you want to be challenged, you want to apply this in your
and there are other ways to do it. You don't have to do it like I did, where I went all gung-ho and say, okay, enroll in the program and do everything else, right? If you have limited time, do the transitional DPT, right? Because the workload is easier. And then when you do the DSC, your DPT they will give you academic credits for that. So then your DSC program will only be half, not like me where I had 65 units. There's a lot. Or if you do not want the demand of being in an academic class, do the continuing education if you want for the OMPT, take the on-site classes, prepare for the exam, which is at your own pace. And then when you're done with the CMPT, COMT, and the spinal management therapy class, whether it's Aspire or NIOM, they will give you academic credit for that when you're done. And then you enter the DSC program. Does it make sense? So you don't have to do what I did, where you did everything all at once. You can do them bits. You can do the clinical training, the OMPT, do the fellowship. When you've done the fellowship, you can still do the DSC, but it will be at half of the academic credit. So it will actually be lesser work and actually finish it in 3 years. Not like me, that's going to take money.
Right.
Yeah. So that's another, So that my advice would always be to, like, you don't have the time, don't do what I did. Do like the other way, like I just told you, do it bits and pieces and then just apply it. So in the end, you will still have the degree. Yeah.
Right. Good. You dip your toes in
Yes.
stuff first and see if you wanna.
Yeah. Because there's no pressure if you're not in academic class. You can take the exam when you need to, when you want to, and you can just study when you have the free time, and not where if you're in academic class, you have to take that exam within the 3 months or 4 months of that academic class. So you really have to study. Yeah.